We move back to the anterior segment again, and in the next 10 minutes or so I'm going to be talking to you about scleral grafts. To make this technique applicable, I've sort of expanded the indications not just to necrotizing scleritis but certain other cases as well, which you will see. So we remember that necrotizing scleritis has 50 to 70% perhaps association with grave systemic diseases, which includes ANCA positive vasculitis like Wegeners, rheumatoid arthritis and polyarthritis nodosa, and these are examples of those. This is a patient who has rheumatoid arthritis, which you can see in the extremities, but what the patient has in the eye is a sort of a Scleromalacia perforans, which if this patient is sequentially followed, you see that there is progression in the area of anterior staphyloma. But this epithelium is well epithelialized. There is a thin area of fibrous tissue and the blood vessels are in order. So you don't need to do a patch for every patient that you see who has disease, even if it's progressive. You need to manage these patients with systemic immunosuppression. So you can also have corneal involvement. In this case, this is maybe Morin's ulcer where you have a perforation, but in this case you have a patient with peripheral corneal ulceration with scleritis, and this patient also has rheumatoid arthritis. So in this instance, you would have to also deal with the corneal pathology. Again, another example of cases where you don't necessarily have to go for a scleral patch graft. This is a patient who presented to us with peripheral ulcerative keratitis and as well as this area of necrotizing keratitis, scleritis, which almost looks like it was infected, but we did scrapings and they were sterile. And subsequently, the patient turned out to be ANCA positive. We diagnosed the case as Wegeners granulomatosis, and by starting the patient on immunosuppressives, including systemic IV cyclophosphamide, this area healed very satisfactorily, and this patient did not need a patch graft. Another patient who has relapsing polychondritis followed up over time. This is area of scleral thinning. Again, you don't need to put a patch graft. So I thought I'm talking to you about scleral patch grafts. So what are the indications for those? You really need a scleral patch graft in cases where there is tectonic threat to the eye. For example, in cases of surgically induced necrotizing scleritis like this patient here, who underwent pterygium surgery and has a punched out defect. There's diffuse scleral inflammation all over. In addition, patients with Scleromalacia perforans, there could be progression and breakdown of the epithelium, patients with Wegeners granulomatosis, and also cases of infectious scleritis. The expanded indications that I mentioned earlier would include scleral melts, perhaps following mycotomycin C after pterygium surgery, and you might have exposed buccal, suture, and other causes for scleral melt. Vinita has talked to us about preoperative immunosuppression. There is no other case where this is even more applicable, that when you want to take up a patient with necrotizing scleritis, you must immunosuppress the patient adequately, preoperatively. In addition, you need to have a long-term plan. What would you do after the graft? Otherwise, the same disease process will continue and you would have failure of your graft. Some of the investigations that you want to have on hand before you take up the patient for surgery would include these. And in cases where you suspect either an infection or perhaps a masquerade like a tumor, you want to include either impression cytology or send tissue for biopsy in these instances. So I'll start off with some of our examples. There's a patient who had pterygium surgery recently, and what you see is a large area of scleral melt. In addition, the entire eye looks inflamed. There are areas of what looked like small little focal abscesses. So we had a working diagnosis of surgically induced necrotizing scleritis, and our plan included scrapings from that area. We sent the patient's lab investigations, but they didn't yield anything. ANCA was negative. So we started the patient on oral and started the patient on systemic steroids, including intravenous methylprednisolone as well as cyclophosphamide. And this surgical video shows that what my colleague Dr. Sangwan did is that we wanted to explore and see what was the posterior extent of this area of thinning. So he saw that it was involving the rectus muscle, so he had to disinsert the muscle, and of course in the end it was put back in place. So actually had to use the help of the squint colleague to do this. So this part shows that the muscle was disinserted. And this is a freehand dissection of a scleral patch which was fitted into place, just freehand, and sutured at the limbus and covered by conjunctiva, and the entire surface was then covered by amniotic membrane. This patient proceeded to do pretty well and was on long-term follow-up with us. The vision improved. The patient was given oral steroids for about 6 months in a lower dose subsequently, and also we put the patient on endoxan for about 3 months with regular monitoring. And this is one of the follow-up later on. The patient a year later also underwent cataract surgery. You can see how well the graft has taken up. The tissue is well epithelialized with conjunctiva, and the blood vessels have once again repopulated this area. So this was a case of successful treatment for us. A second case was a 54-year-old lady who underwent pterygium surgery and presented to us with a discolored patch that she noticed in the eye with pain and watering. And what we noted right away was that there was a punched out lesion which would correspond to the area where the pterygium was, and there was exposure of the uvea in this area. Notice how the conjunctiva has just stopped growing over this defect, whereas the rest of the eye was not that alarmingly inflamed. So in this particular case, we diagnosed her more as a case of post-mitomycin C scleral melt, if you want, because this patient, mitomycin C was used topically after the therapy, after the surgery. And in order to cover this rather large area of scleral necrosis or melt, we resorted to a scleral patch graft. So what you see here is the conjunctiva is dissected. This is the unhealthy tissue which is just around the edge of the melted area of the sclera. So that was dissected out and the area debrided. Freehand measure it, and this is preserved sclera, which is really very thick if you want to put the entire sclera in place. So what you can do is you can make it half thickness by a very simple freehand technique with the help of an assistant, or with a crescent knife, or simply a 15-number blade. And once you do that, you can suture this in place. Perhaps it would be good to put the cardinal sutures with sutures, and the rest of it you can use fibrin glue and just tack it down in place with the help of glue. So this is trimming the graft to fit snugly over the area of defect in the eye. So again, this patient did very well. This area was covered because the conjunctiva was unhealthy, as I mentioned. So autograft was taken from the same eye to cover the area of bare sclera. You cannot leave this area exposed. You should either use conjunctiva from the same eye or the fellow eye. If the entire eye is extremely inflamed, you can't use conjunctiva from the same eye. Or you can use amniotic membrane if you have that. So this is fibrin glue used to tack down the conjunctival autograft over the scleral patch graft. This patient also received oral steroids for about 2 or 3 months, but then since we knew that the patient had received mitomycin C, and that was the cause of the scleral melt, and it's not truly a case of SINS, so we could just taper and discontinue the steroids soon after. So this is the post-operative outcome. About a month post-operatively, you can see that already the vessels have, this is autograft anyway, but the edge of the graft sits well in place. Patient did not have a Dellin effect and is continuing to do well. This patient happens to be one-eyed. The other indications that you could use a scleral patch for, this was a 23-year-old patient who was diagnosed with Marfan syndrome and ectopia lentis, underwent transplant lensectomy with transscleral fixation of PCIOL, and he presented with a lot of discomfort and irritation discharge from the eye 7 months later. And when examined, you could see that there was this area of exposed suture with underlying sort of melt of the scleral tissue, and of course there was giant papillary reaction in the upper tarsal conjunctiva. My colleague Dr. Taneja did a simple technique of lamellar scleral patch graft. He first opened up the conjunctiva and exposed the exposed suture, which he then trimmed flush to the surface of the sclera, measured the area of scleral deficit or thinning, and this is actually it's a dermal punch. It's a 3 millimeter punch, but it's easily available, and he dissected out the unhealthy overlying tissue to have a clean bed, to have a smooth surface. And once this is dissected out, he used the same punch onto donor sclera, and he's already marked the outline. He's just using the help of a blade to sort of delineate the edges of it, and he's going to prepare a lamellar kind of small patch, scleral patch, a rounded patch, which he's going to put on the area of the deficit. And this is very tiny, it's about 3 millimeters, so you just need to put it back in place with fibrin glue. And since this is not a progressive necrotizing kind of process for the patient, it's a one-time event, you don't need any oral immunosuppression for this patient whatsoever. And we have long-term follow-up which shows that at the end of 1 month itself, you can see the edge of it, but it's integrated into the eye very well. And this is 7 months, you really are hard-pressed to try and see the flap. So you can use other tissues, you can use corneal tissue, you can use multilayered amniotic membrane, and even fasciolata, periosteum, etc. has been described. But the advantage of using sclera is it's technically easy and you have access to it because you can preserve sclera. Indications are you require it in progressive cases where they are tectonically at risk. And although you need to have investigations, need to have the reports, but very often they are negative. Sometimes you may use your clinical judgment and not have the patient spend a lot of money on some of these investigations. But the more important thing is to have the patient spend money on immunosuppression. Problems that you can have sometimes when you do scleral patch grafts is you can have sort of a melting of the graft. So this was a patient I had shown you earlier who presented with cysts, and then we did a scleral patch graft. But what's happening is that the vessels are not growing over, the necrotizing process is continuing. So we had to step up the systemic immunosuppression for this patient, again resort to intravenous methylprednisolone, and all the sutures became very loose because this entire graft was edematous. But after stepping up immunosuppression, we could retain this graft in the eye after removing all the sutures, and then subsequently we had to put a conjunctival graft from the other eye onto this area which was kind of bare sclera, and somehow managed to retain the function for this patient. A patient where I had used amniotic membrane with fibrin glue. So this is an area of scleral melt due to infection, and there just after the infection healed, I had tacked down a sort of a multilayered amniotic membrane. But what happened is sometimes the glue doesn't hold the tissue in place well, and this was just a week later that the entire amniotic membrane just crumbled and falling off. So we had to go back and repeat it using a scleral patch in this patient. Any questions?